Yes, sir. So, good afternoon, everyone. It is my privilege to welcome all of you to today's webinar. I would like to extend a warm welcome and express my sincere gratitude to our respected chief speaker, Dr. Rakesh Gupta, President and Director of the Strategic Institute for Public Health Education and Research, and subject expert Dr. Rakesh Gupta, President of Rajasthan Cancer Foundation, Jaipur, Rajasthan. We are truly honored to have you with us today, and we sincerely appreciate your valuable time, guidance, and expertise. I would also like to extend a warm welcome to all the participants present here today. I will be presenting my desk review titled From Dependence to Recovery Understanding Nicotine Addiction and Cessation in India. Before I begin my presentation, I would like to invite our esteemed speaker, Dr. Rakesh Gupta, President and Director of the Strategic Institute for Public Health Education and Research, to kindly address us with his introductory remarks.
So thank you, Priyanshi. So please show me the introductory slides. Yeah. Next, please. So the nicotine, it is a primary addictive chemical present in tobacco products and all new emerging nicotine tobacco products as well. And it affects the brain reward system for releasing dopamine, which can lead to dependence. Tobacco or nicotine is consumed in smoked and smokeless forms and as new emerging nicotine tobacco products in India. Nicotine addiction is influenced by biological, psychological, behavioral, and social factors. And tobacco use is a major contributor to preventing diseases and premature deaths. And understanding nicotine addiction is essential for developing effective cessation strategies and improving the public health. Thank you. Next, please. India has one of the world's largest tobacco using populations. Tobacco is consumed, as already told, that it is consumed in smoking, smokeless forms, and as new emerging nicotine tobacco products. And tobacco or the nicotine that contributes to preventable diseases and deaths. Tobacco cessation is essential for improving the public health. Next, please. So objectives of the study were understanding nicotine addiction and dependence, study the psychological and behavioral effects, review the tobacco cessation strategies, examine the tobacco control policies in India, exploring the new emerging nicotine and tobacco products, and suggesting recommendations for improving the cessation facilities available in India. Next, please. And as you may be knowing, that the nicotine that causes addiction, and it is contained in tobacco products as well as new emerging nicotine tobacco products. Then in tobacco smoke, carbon monoxide that reduces oxygen flow, tar damages the lungs, and the toxic chemicals, they are harmful to health. Next, please. Nicotine addiction in India is highly prevalent, and tobacco use often begins during the adolescence, and there is because of peer pressure, stress, and social acceptance that influences the addiction, and nicotine dependence that affects both physical and the mental health. Next, please. How tobacco affects your body? Nicotine is a vasoconstrictor, so it affects all the organs of the body from head to toe, from hair to toe, actually. And it may lead to oral and lung cancers, cardiovascular diseases, chronic obstructive airway diseases, stroke, hypertension, respiratory illnesses, and the quality of the life of a person is reduced if he consumes tobacco or nicotine. Next, please.
Should I continue?
Yes. Next, please. The psychological and behavioral effects of nicotine, they are the strong cravings and nicotine dependence is there. Then the withdrawal symptoms like anxiety, irritability, and restlessness are there. Emotional dependence and the stress coping is there. And habit formation, it is habit forming, and conditioned behavior is there. Peer influence and social acceptance is there. Increased risk of relapse without the support is there. Next, please. So you can continue with the methodology. Yes, Priyanshi.
Yes, sir. For this study, I reviewed information from credible national and international sources, including the WHO, GATS India, MOHFW, NTCP, NIMHANS, CDC, NIDA, Sipher webinars, and peer-reviewed journals. The collected information was organized into themes such as nicotine addiction, health effects, cessation approaches, tobacco control policies, and emerging nicotine products. Since this was a desk review, no primary data or human participants were involved. Research design. Used a desk review research design, which means it was based entirely on secondary data rather than primary data collection. Information was gathered from reliable reports, research articles, and government publications to understand nicotine addictions, tobacco cessation, and tobacco control in India. This approach allowed me to review existing evidence and present a comprehensive overview of the topic. Tobacco cessation approaches. An important focus of the study was understanding how individuals can successfully quit tobacco. Research shows that the most effective approach combines behavioral counseling with medical support. Behavioral counseling helps individuals identify triggers, manage cravings, and adopt healthier coping strategies. Cognitive behavioral therapy, or CBT, focuses on changing negative thought patterns and behaviors associated with tobacco use. Nicotine replacement therapy, including nicotine gum, patches, lozenges, helps reduce withdrawal symptoms and improves the chances of quitting successfully. India has also introduced tobacco cessation clinics, quitline services, and digital interventions such as WHOM Cessation, which provides continuous guidance and motivational support. Finally, relapse prevention is a key component of recovery as many individuals require multiple attempts before quitting successfully. Continuous counseling and family support play a vital role in maintaining long-term abstinence. New emerging nicotine and tobacco products. In addition to conventional tobacco products, India continues to see the widespread use of cigarettes, BDs, and smokeless tobacco products such as gutka, khani, and chewing tobacco. BDs remain popular because they are inexpensive, while smokeless tobacco is strongly associated with oral cancer and other serious health conditions. Alongside these traditional products, newer nicotine products have also emerged. Oral nicotine pouches, or ONPs, are tobacco-free pouches that deliver nicotine through gums. Although they are marketed as safer alternatives, there is still limited evidence regarding their long-term health effects, particularly in the Indian context. Hookah and e-cigarettes have also become increasingly popular, especially among young people. Many users believe these products are less harmful than cigarettes, but they still contain nicotine and other harmful substances that can lead to addiction and adverse health effects. These trends highlight the need for greater public awareness, stronger regulation, and more India-specific research on both traditional and emerging nicotine products.
Yes, Priyanshi, actually in new emerging nicotine and tobacco products, there's one product called as heated tobacco product, like the popularly known as IQOS. So
Yes,
that
sir.
should also have been mentioned here. Thank you. BDs and chewable products, they are not new emerging nicotine tobacco products. They are
Yes, sir.
old.
Acknowledge, sir. Tobacco control policies in India. To reduce the burden of tobacco use, India has implemented several important tobacco control policies. The Cigarettes and Other Tobacco Products Act, commonly known as COTPA 2003, regulates tobacco advertising, promotion, sponsorship, and smoking in public places. It also mandates large pictorial health warnings on tobacco packaging. Another important initiative is the National Tobacco Control Program, which focuses on increasing public awareness, implementing tobacco control laws, establishing tobacco cessation centers, and strengthening surveillance. India has also adopted smoke-free public place regulations, restrictions on tobacco advertising, and educational campaigns to discourage tobacco use. Although these policies have shown positive results, challenges such as weak enforcement, easy availability of tobacco products, and limited public awareness continue to affect our overall effectiveness. Therefore, stronger implementation and community participation are essential for achieving long-term reductions in tobacco use. Discussion. The findings of this desk review indicate that nicotine addiction is a biopsychosocial disorder, meaning it is influenced by biological, psychological, and social factors. Biological nicotine changes the brain's reward pathway, creating dependence. Psychologically, stress, anxiety, emotional regulation, and habitual behavior encourage continued tobacco use. Socially, pressure, family influence, cultural acceptance, and easy availability of tobacco products further increase the likelihood of addiction. The review also suggests that successful tobacco cessation requires more than simply asking people to quit. It requires behavioral counseling, psychological support, pharmacological treatment when appropriate, supportive policies, and continuous follow up. These findings reinforce the important role of psychologists in helping individuals understand their triggers, modify unhealthy behaviors, and prevent relapse. Overall, tobacco control should be viewed as a collaborative effort involving healthcare professionals, psychologists, educators, policymakers, NGOs, and the wider community. Key findings. Based on the literature review, several important findings emerged from the study. First, tobacco use continues to be one of the leading preventable public health problems in India. Second, nicotine addiction is influenced by a combination of biological, psychological, behavioral, and social factors, highlighting the importance of a holistic approach to treatment. Third, behavioral counseling, cognitive behavioral therapy, nicotine replacement therapy, tobacco cessation clinics, quitline services, and digital interventions such as cessation have demonstrated positive outcomes in supporting tobacco cessation. The review also identified growing concerns regarding emerging nicotine products such as oral nicotine pouches and hookah, particularly among young people. Finally, stronger policy implementation, greater public awareness, early prevention programs, and increased access to cessation services are essential for reducing tobacco related harm in India. Sir, please continue.
Yeah. So the way forward is strengthening the tobacco cessation clinics or the TCCs and counseling services. And we need to improve the awareness among the adults and the young adults, expand WHO administration, then the national quit lines, and mobile-based support. And we need to increase access to the nicotine replacement therapy, NRT, and conduct India-specific research on oral nicotine pouches, strengthen the enforcement of the COTPA, integrate the tobacco education into schools and communities. Next, please. Nicotine addiction that remains a major public health challenge in India. Addiction is influenced by the biological, psychological, and social factors. And evidence-based cessation approaches they improve recovery. India's tobacco control policies have made progress but require very strong implementation. Prevention, awareness, and early interventions are essential. And then the collaborative efforts can significantly reduce tobacco-related harms. Next, please. Then the recommendations are for the policymakers, we need to strengthen the implementation of COTPA and other related laws, increase funding for tobacco cessation services. For public health organizations and NGOs, we need to expand awareness campaigns and community outreach, promote the WHM cessation and quitline services. Then for education institutes, we need to integrate tobacco education into school and college curricula and conduct the regular awareness programs for adolescents. For mental health professionals, we need to provide the behavioral counseling and relapse prevention support, encourage the multidisciplinary approaches to tobacco cessation. Next. So thanks, and I'm going to tell you that Priyanshi is an intern with Sipher, but she's a non-medico and she's not a public health student as well. So she has done a good job, I think. It's a very basic presentation, but Dr. Rakesh Gupta from RCF will comment upon the presentation, please. Thank you.
Thank you, Dr. Rakesh ji. Yes, indeed, it's a very short presentation.
Yeah.
And I believe that definitely more can be said, much more can be said.
Yeah.
And you are also pretty experienced to have talked about certain more aspects which are actually currently the needs of the country in tobacco cessation. But before I really dwell upon it, I just wish to know, because in the audience, I see most of the people are already oriented to several aspects of tobacco cessation. And they may not be practicing tobacco cessation delivery as such, but I don't see that there is a need for talking about the aspects of tobacco cessation delivery to everybody at the moment, because this I don't consider it as an appropriate platform to do that. Nonetheless, I feel that the biggest challenge we have is the burden of tobacco users who should be quitting tobacco. And main reason as to why people don't quit is that either they do not know the benefits of quitting, or they have attempted quitting in the past, as the guest too has suggested that over 50% have attempted quitting in the past, and about 60 to 70% are addicted to nicotine. So I consider more information, awareness, IEC or media exposure should be given for the benefits of quitting. The ministry has started doing that, but I think that requires to be more intensified and more widely circulated. And now that we have the social media platforms also, I think more investment should be made into uh, seeing that these benefits are also provided to all the social media participants every time they open their platform. That perhaps may help people to know as to how beneficial the quitting can be. And in fact, there is no doubt that these are inversely proportional, the intake versus quitting. That if you continue with the intake, as we have seen from the evidence, on an average, with the lifetime use, people lose about 6 to 10 years of their lives, and the loss of premature lives bring about the decrease, the loss of productivity, and fall in economics of the country. So I think it's very important that benefits are highlighted, because benefits, the day you start, you quit, the benefits start. And there is a sort of relationship in the form of their compounding, so that benefits keep multiplying, so much so that after 12 to 15 years, a person who has never had any tobacco related illness will eventually become free of the risks which he had incurred by the use of tobacco. I think now it has become mandatory to mention specifically about the nicotine also. And we all know that nicotine is the addictive substance in tobacco. And it's therefore no surprise that if there was no nicotine in tobacco, people may not have used tobacco at all. But now that we have the challenge of the nicotine products as such, in form of e-cigarettes or e-hookah, heat not burn products, or now that oral nicotine has come, I think it's very important that people also know about the adverse effects of nicotine products and the need to quit them as well, similarly to the tobacco products. So I think that's the second point that I wish to make here. I think in the tobacco cessation delivery process, the country has to go a long way, because I think the primary need is to improve in the resources and the infrastructure. And in the resources, I feel funding is very important, crucial part actually, that if you don't provide the funding in time to the states and to the national quit line, they will not be able to appropriately manage their tobacco cessation clinics and also the quit line services as such. And we have seen the data from these quit lines in a fractionated manner, though, and also partly from the tobacco cessation clinics to the NTCP uh, website. And I feel that there is a lot which requires to be done to improve the performance of these cessation services. So it's great that we have the availability of the toll-free services or the free services to the tobacco cessation clinics, which also provide the nicotine replacement therapy and bupropion for free. But I think we need to really, in a focused way and in a specific manner, see that the resources are provided in a continued manner and on a sustained basis, because that's the only way to increase the quit rates in the country. And I think infrastructure needs to be improved both in TCCs and in quitline. TCCs, of course, at many places do not have even the rooms. They are sharing the rooms with other consultations or with the OPDs of other people. There are some places where the TCC person sits with 4 or 5 people who are practicing their specialties or their branches in satellite hospitals or in general hospitals. So that's a big challenge. You cannot really give the proper consultation to the people at the or the counseling to the people who are coming there to quit tobacco. You require some kind of privacy, ease of the delivery. So I think that cannot happen in such a scenario. So that's one part, that in hospitals, yes, the room may be smaller, but at least it should be able to accommodate a table and chairs across the table for people to sit and a staff to help the person who is delivering tobacco cessation and to manage the data. I think that's very basic need for a tobacco cessation clinic, and that should be ensured by the state departments or the NTCP cells in the center and in the states and union territories, that all the tobacco cessation clinics have proper human resource and infrastructure. There are many places where the human resource is also not available, or if they are available, they have not been trained in tobacco cessation delivery, because sometimes they put the counselors from other areas like NCD control or from the mental health or for the adolescent counseling, etc. That's not right, actually, because tobacco cessation is a very specific subject. It's quitting, we all know, is difficult, if not impossible, and it requires a very committed effort and also requires a lot of knowledge of the person who is doing that. So I think that part is very, very important in running TCCs. Similarly, in the national quitline services, I consider we need to really think as to why we have not been able to improve in our NTQLS services. Despite lakhs of hits that we have, our number of the people who successfully quit are just few thousands. So I will not name the regional NTQLS service, but in one of the services, when I found the percentage of successful quit versus the number of hits, I found that the success rate was just about 0.02%. Now, for whatever that they have done, and they are doing it for last so many years, this is a very insignificant output. And therefore, a serious review is required. And what I consider is that what is most important is that those people who are registering for quitline, they do not get the prompt response. And it's very important that a person, when he is motivated to quit, he is given the due support in time, appropriately, and for as long as he requires. These are three very, very, very important things. But if the counselor is calling because they are very busy with other people, after some time or after a few weeks, I think that motivation, the desire or the desire to quit or the motivation just goes away of the person. Person may not respond, and therefore we find that the quit rates have become low. So I consider that quit lines are one of the best portals we have for helping people quit, because it has ease of not going to a hospital. It is done in the confidentiality. It is done in an easy manner through the person's convenience, and it also has very important aspect of maintaining the data and provides the inputs for the research. But I think it's very important that the regional quitline services get proper infrastructure in the form of number of counselors and the desktops which are required for running the services and for maintaining the data. So I think it's very important that you require large number of data managers and statisticians also to continuously monitor what is happening in a quitline. And also, I think the NTQLS has to expand. In a country like America, I saw that there were several quit lines, and there are state-managed quit lines, or even if these are national quit lines, every state has its own quit line as well. And they also have the institutes of quit lines. So I think it's very important that looking into our burden, every state should have a subsidiary of national quit line. And this can be done. I have been telling this for last 10 years almost, that through the state helpline services, where there is already human resource and infrastructure, these are the people maybe who may be trained, some of the counselors who are already there, or more chairs may be put in, 4 or 5 chairs. That will perhaps be giving a better service to the people who are desirous of quitting, and it can be done promptly. So I think funding is very important. Improving the strength of the human resource is important, and also the infrastructure. These are three things which are very important in the delivery. Thirdly, I would say that the human resource, and we have plenty of it. I fail to understand as to why the healthcare professionals, not only doctors, but nurses and other staff, pharmacists, etc., are not engaged in the cessation delivery. We may not be they may not be all able to do the intensive intervention, but nothing prevents them to do the minimal intervention and brief intervention. And it's good that the vital strategies have come out with a proposal that we should have a brief advice at least given to all the tobacco users who are coming to any health center, and nobody should go unattended. It's time that we promote, not only promote, but we establish brief advice as the way to go forward for all tobacco using patients whenever they come to a health service. And for that, we require a systems approach where I think it's very important to understand that the health management, hospital management should have the software. Now, most of the hospitals have softwares for the insurance claims. Why cannot they have the hospital software when they are making the registration of the patients for tobacco use? Is something which is doable, but they are just in a way reluctant to do it. So I think it's very important that they integrate within the software to register for the tobacco use, not only the current use, but the former use also, their desire to quit, whether they have attended the tobacco cessation clinic or not, and what treatment they got, and how they are followed up, so that the hospital also comes to know what is the quit rate of the tobacco cessation clinic at its own facility. It's very important to do that. And I think in particularly in case of the private sector hospitals, and mostly at the secondary and the tertiary care level hospitals, it's important that the government mandates the establishment of tobacco cessation clinic. And I think that is something which is required to be done. So, Neetu ji, can you put your mute yourself?
I muted him.
Okay, thank you. So I think that is very important aspect that the health management and healthcare professionals get engaged appropriately into this, and nobody will do it voluntarily. That I can assure. The human behavior is such that it requires little bit of administrative whip for following up the instructions. So unless there is a policy set by each and every state or the country as such, that all the private hospitals, because the private health sector is a bigger sector, it's very important that all these hospitals should also be under the policy of the state or the nation for establishing TCC and for delivering tobacco cessation. Also, it's very important that now we are in the era of the health insurance. All the health insurance agencies, they should have a provision for charging higher premium for those who are tobacco users, and if they don't quit tobacco within a year of their registering for the insurance purpose. And also, the insurance agencies should be making the reimbursement for the expenses made on the tobacco consultation, tobacco cessation consultation, and for the medicines which the people buy, or it becomes a sort of free thing, so that they are not, this is kind of cashless arrangement which can be done. So that I think is also very important. And I think in your last webinar, Dr. Rakesh, you talked about the digital cessation facilities. We have started talking in India about it. PHFI is also developing that facility.
Right.
Vikrant Mohanty also talked about it in his webinar on this while he was doing it for the National Quit Line. NIMHANS perhaps also is pretty well equipped to do that. So I think it's time that we have very many portals or the services which cover under the digital cessation. Maybe it will help, but we'll have to see through our studies as to how the youth can be engaged into quitting tobacco, because we do know from our GYTS data that only 20 to 25% tobacco users between the age of 13 to 15 years who were surveyed in the fourth or the latest round of the GYTS were desirous of quitting. That means 75% are still not willing. So their empowerment, motivating them to quit, and helping them to quit in time. I think these are all very important aspects. The digitization itself requires more awareness plus the orientation and empowerment of all those who will be engaged into it, and also the adequate resources, so that digitization eventually becomes something which is more easily accessible, more affordable, and also more useful tool for helping people quit through the apps or through the direct services which may be provided by the centers of excellence. I think it's time that even the resource center for tobacco control takes the initiatives for expanding the domain of tobacco cessation within the country through its recommendations to the ministry, that it provides the suitable resources. We have done that through the National Academy of Medical Sciences, which asked us to prepare the report on tobacco control. And as task force, we have submitted those recommendations. I think those require to be fulfilled, as well as the recommendations which were made by the people who prepared report on tobacco control in India in 2022. So these are some of the aspects which I thought I should be pointing to. But it's a long topic, it's a broad topic. One can speak for many hours on this aspect, but more interactive if it is, it will be more beneficial. So,
Dr. Rakesh Gupta, can you briefly talk about that brief advice? Because everybody is a stakeholder in tobacco cessation also.
So, brief advice is actually asking the person that whether he or she is a tobacco user, and if the person is a tobacco user, advise in a very clear, strong voice that you need to quit tobacco because tobacco is toxic and it can be fatal as well as it is addictive. And I can refer you. The third component is referral, ask, advise, and referral. And so I can help you refer your referral to tobacco nearby tobacco cessation clinic or to the National Quit Line Service. So these are three components versus the traditional way in which we help a person to quit through 5 A's and 5 R's for those who are unwilling to quit. So brief advice is something which is more easily doable. Within 2 to 3 minutes, you can help a person and at least motivate him to quit tobacco.
Yeah. So over to Priyanshi. Priyanshi, can you just briefly tell about Dr. Rakesh Gupta, because you missed it earlier?
That's not required. I think we have Dr. Rakesh Gupta, Dr. Dilip Acharya, Susan, they are all there.
We'll
So
ask from them also their comments. Yeah.
thank you.
Yes, Priyanshi.
So I would like to express my heartfelt gratitude towards Dr. Rakesh Gupta, President of Rajasthan Cancer Foundation and a renowned public health expert in tobacco control. He's a recipient of WHO World No Tobacco Day Award 2013 and has worked extensively with national organizations such as Ministry of Health and Family Welfare, PHFI, and RCTC. Dr. Gupta has played a key role in developing tobacco cessation programs, mentoring healthcare professionals, and promoting India's visions of a tobacco and nicotine-free future by 2030. We are truly honored to have him with us today. I would also like to acknowledge the presence of Dr. P.C. Gupta, Mr. Jain, Mr. Saini, Dr. Dilip Acharya, Dr. Aruna D.S., Advocate Gagandeep. Please, sir, share your remarks with us.
Yeah, Dr. P.C. Gupta. Yes, sir.
Thank you, Rakesh. I heard these presentations and recommendations also I saw. I would just make one comment. I think a lot has been said and can be said, but one particular clarification I would like to do is one recommendation is further research is required for these newer tobacco products. Now, my plea is that we don't have to waste time and resources in thinking and researching on the health effects of these new products, because that is not the central issue. The issue is that they contain nicotine and they are addictive. they are habit forming, addictive, and the addiction itself is a disease that needs to be treated. So, if there are alternative nicotine products, they need to be discouraged in every way. And as you have already discussed, Rakesh has also, both Rakesh have talked about, and Priyanshi has talked about cessation and de-addiction, that those are the very important aspects that need to be considered. Also, of course, initiation. The cessation is important only because some people initiate. So the initiation is also important. And the research is required that is about marketing and promotion of these products, that how is it that these products are getting marketed, even if many of them, all the vaping products are illegal in India, vaping and heat not burn products, and how it is that they are marketed and they are still reaching adolescents and children and population. So those are really the issues that need further research and ways of preventing those, and ways of whatever has been discussed, cessation and de-addiction. But very important to focus on these issues. So thanks very much, Rakesh, and for this webinar.
Thank you.
Back to you.
So Dr. Rakesh Gupta has raised his arm. His hand.
I have just missed on mentioning my last point, that was on the integration of tobacco cessation within the tobacco endgame, which we have been envisaging for the country. I think we have set the timeline for December 2030. I think we should make a national policy that all those who are current tobacco users, they should quit by December 2030, howsoever, because thereafter the tobacco products should not be made available to them. That's one way to motivate and accelerate the rate of quitting, the attempts at quitting in the country by the current users. People take it as a business as usual. They are not worried. They think whenever I think I'll be able to quit. But these are all myths. The myths are also because the people consider tobacco as a socially accepted, usable product, which is not right. People consider tobacco industry as one usual industry. It is not. It is deceptive, and it is the industry only solely for profit at the cost of, I mean, for making wealth, but at the cost of the lives of the people. So I think end game should also be considered by everybody. People should know what end game is, and it has two components. End means that to end all the activities of tobacco industry by a particular timeline, within a timeline or a particular date. And game is the strategies, what strategies we will have. So tobacco cessation is one very important strategy. However, it requires to be implemented little forcefully. I mean, it will never be unethical, or it will not be a breach on the fundamental rights of the people. Liberties are given in the limited way. People don't understand the government has the responsibility that it helps people or coerce them a little to make them quit tobacco, which is an addictive product.
Yeah, right.
Okay.
Actually,
Thank
I
you.
was going to ask about the end game, which is your favorite subject. And I think we urgently need to discuss about it and recommend to the authorities. Rather, we should meet the health minister and the PM also, if required. Thank you. So,
Thank you.
may I ask Dr. Dilip Acharya for his comments, please?
Yeah, good morning, everybody. Actually, I missed the early part of the talk, but I did hear the recommendations, extensive talk by Dr. Rakesh Gupta also. I do agree with him on many points. As we all know, we have a very poor status of cessation services in India. Although 1.5 years back, I remember NMC had issued instructions to all medical colleges, government and private, to have a cessation clinic with a de-addiction clinic also with them. And already the dental college is already having this center. So now we have what 1,100 plus centers across the country. But I don't know whether the counselors have been trained. Do they have a counselor? Whether the doctors sitting there, they have been trained or not? The Ministry of Health should work on it to get a proper feedback. How many of them are working? and what are the results they have obtained of it. Because poor cessation clinics will not help us in any way. We have to work on it hard to go for it. So similarly, apart from this training of other doctors, we have approached the Ministry of Health a few times earlier because we wanted to train our IMA doctors in tobacco control. Although WHO has been helpful to us in arranging few workshops or something, but more needs to be done to train the doctors in tobacco control, because I think that they are the grandmasters to this thing. And when a doctor says something to a patient, people are ready to listen much more rather than going to give a talk in the number of places. But if the patient is there, the doctor's voice is heard much more and taken more seriously. So we should all work more on tobacco cessation, which is not there. Talking of the rules, we all know similarly that e-cigarette was banned in 2019, and cricketers were seen using e-cigarettes. So why they should be available in our country when it has already been? So is that the implementation of the law is not there?
Yeah.
So the Ministry of Health should see to it that the laws which are framework were implemented. The COTPA amendment was overdue. Still, they have up to 200 rupees fine, but it was proposed to go to 1,000 or 2,000 even also. So all these things will also help people to think of quitting, also increase.
If I may come in again here, Dr. Rakesh ji,
Yes, sir.
following up on the interactions and input provided by Dr. Dilip ji, I consider he is in one position as the committee member of the National Cancer Prevention and Tobacco Control of IMA. IMA itself is a pretty strong body and it should take it up. And recently, I was fortunate to be awarded by our state IMA for the preventive services in the state of Rajasthan, specific to tobacco control. So it's a good beginning. I think a few strategic initiatives may be taken by IMA. One I consider is that it should empower all its members in brief advice. It should empower all the owners of the hospitals who are the members of IMA to start with the TCC clinic. And I think it's time also that they start giving the annual awards which they are giving, state chapters are giving to its other clinicians, for the specialist and other people for the work in the prevention uh, area, and specifically to the tobacco cessation and tobacco control. These are three specific requests I have, and also to talk about tobacco endgame.
IMA has already been working about it for a long time, and we continue to do it.
Thank
Thank you, Dr. Gupta.
Yeah, thank you. Miss Susan for her comments, please. She's from Gujarat.
A very good afternoon, everyone. I find cessation a very interesting aspect of Empower module also, and all of us would definitely want to agree, and even Dr. Rakesh Gupta said, and I want to second Dr. Dilip Kumar Acharya's statement saying that we are not very sure of what is the status of TCC. It's the most unmonitored, unresearched, under-documented aspect of Empower, offer help, So I think we need to focus on also documenting it well, producing it in terms of statistics, research, and data. We being able to do it in helpline, I understand that, but how many of the beneficiaries or all the centers doing well? So that is one aspect I think is we need to focus very much on. The another aspect I wanted to focus also on vulnerable groups, especially gender-specific cessation services that we can provide, because no matter how much we ignore it, rural women are into tobacco addiction, and especially SLTs. Young girls are getting into BD addiction as a style statement in cities, and emerging products are a challenge. So we need to also focus on gender-specific vulnerable groups. They can be migrant women, they can be ANC mothers. I have been taking up ANC mothers for a while now, but then that is also something we can focus upon. And again, I also second the idea that it is one of a very important component of endgame, tobacco endgame that we see in the country now. And we need to start talking about it not just as an empower module strategy, but also a very important aspect of tobacco endgame in the country. So these are my three suggestions or my take on the end presentation. Thank you, Dr. Gupta, for wonderful presentation. Thank you.
Thank you, Susan. And may I just ask Dr. Aruna to give her comments, please? Dr. Aruna is with us? Or Mr. Sani? Mr. Sani if is with us.
Hello.
Yeah, Dr. Aruna is with us. Yeah. Okay.
Hello, sir. Good afternoon.
Yes.
Sir,
You
actually,
can tilt your camera. Make it horizontally.
yeah.
Yeah. Thank you.
Yeah, sir. First of all, the perceiving tobacco as an addictive substance is very low. So they consider like the quitting tobacco, they overestimate their self-efficacy that anytime they can quit, despite like there are very difficulties in quitting the tobacco. So they underestimate the difficulties or the roadblocks they face when they come to the tobacco cessation. And another thing, like their past quit attempts, the failed quit attempts, most of the time that itself will demotivate them. They say that it's okay, like anyhow it is socio-culturally acceptable and easily available, so whenever we want to quit, we'll quit. So this kind of belief needs to be addressed. And moreover, like being a dental health professional, so we are in a position to detect the early changes in the oral cavity. Despite giving the feedback of what's happening in the oral cavity, they first of all perceiving the oral health itself is the harm caused because of tobacco itself is low, unless and until it is a malignancy or a pre-malignant lesion.
You're right. So thank you, Dr. Aruna.
Thanks,
Mr.
sir.
Sani, do you want to comment?
Sir, good afternoon.
Yeah, good afternoon.
सभी को मेरा नमस्कार.
Namaskar.
Sir, I have a humble request from all the respected group that we all together should now raise our voice for end game of the tobacco, as Dr. Gupta sir has already discussed about this. So on every platform there must be a session on end game of tobacco by 31st December of 2030, as sir has decided. So rest we all are doing well in Rajasthan, but the end game is the most important and demand of this time, sir.
You're
Thank
right,
you,
sir.
sir.
Yeah. Mr. Sani, please remain a few minutes for on
Yes,
the
sir.
screen.
Yes, sir. Sir.
I think we must all appreciate what Seniji is doing
Yeah.
by creating posters on tobacco cessation for long, and also now he started with tobacco endgame. So I
Yes,
wish
sir.
to compliment through your platform him for
Thank
his
you,
work. And now that he is retired from the government service, he will have more time to do this work.
Exactly, sir. Yes, sure, sir. Sure.
So may I ask all to just switch on their videos so that Priyanshi can take good snapshots. Yes, Priyanshi, you can take please snapshots.
Yes, sir.
Please ask again. First of all, you must also switch on the video. Priyanshi, your
Yes,
video
sir.
is
Yes,
switched
sir.
off.
I'm doing it.
Okay. Yes.
Done, sir.
Done. Okay.
Thank you.
So you can proceed with the formal vote of thanks, please. Yes, Priyanshi. Priyanshi, are you there? Okay, otherwise I can, yeah, please.
There was some network issue. I'm so sorry.
Okay, it's okay.
Yes. Before concluding, I would like to express my heartfelt gratitude towards Dr. Rakesh Gupta, President and Director of Strategic Institute for Public Health Education and Research, and Dr. Rakesh Gupta, President of Rajasthan Cancer Foundation, Jaipur, for his expert guidance and valuable insights in the field of tobacco control and public health. I would also like to thank you, my entire Sipher team, for providing me with this wonderful opportunity to learn and conduct this test review. Finally, I extend my gratitude towards everyone present here today for your time, attention, and valuable participation. Thank you.
And special thanks to Dr. P.C. Gupta, Dr. Dilip Acharya, Dr. Miss Susan, and who else was Mr. Sani was there. So thanks a lot. Thanks a lot for your comments. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you all. Thank you.
Thank you, sir. Bye.
Thanks, sir.